At the onset, I must thank Sanjay and GastroCare team for giving me this opportunity. Sanjay and me were together in PGI Chandigarh during our DM days, and I must congratulate GastroCare for completing a decade and organizing the 7th session of the annual meeting. Though I believe the crowd is adult gastroenterologists, but they often encounter or deal with children with chronic liver disease. So what I am going to highlight the difficulties you face and how to solve the problem when you are facing a patient with chronic liver disease. If you see, the approach to a child with chronic liver disease depends on the various factors. It is not that like adult that irrespective of the age, you have the similar spectrum of alcoholic liver disease, hepatitis C, or PFIC, like that. These are age dependent. If you consider the infant, they have separate set of chronic liver disease, like mainly it is a cholestatic and metabolic. If it is a toddler, means 2 or 3 years old, there comes a different set like metabolic liver disease, or if it is older children, then comes the common garden variety of autoimmune hepatitis, Wilson disease. Similarly, the spectrum varies with the type of presentation. A child may come with a cholestatic liver disease, then you will consider the different set like biliary atresia, progressive familial intrahepatic cholestasis. There may be organomegaly is the primary presentation. You think about storage disease and isolated portal hypertension. You think about non-cirrhotic portal hypertension. Now, if you take the common causes of the chronic liver disease in the first 4 years of age, again metabolic liver disease will come into the picture, like galactosemia, hereditary fructose intolerance, tyrosinemia, etc. Cholestatic liver disease, like progressive familial intrahepatic cholestasis, often comes in the first 4 years with Alagili syndrome and PSC. But the bigger children, you think about this Wilson disease, autoimmune, chronic hepatitis B, non-alcoholic fatty liver disease, birth carrier, and cryptogenic. Now, what is the disease spectrum? The first two are published literature, last one is our experience. If you see when you talk about the chronic liver disease in general, then hepatitis B is one of the common cause. And then comes your autoimmune hepatitis, Wilson disease, metabolic. But when the last series is our experience of decompensated chronic liver disease. If you see the decompensated chronic liver disease in children, you don't see hepatitis B as the common cause, because they don't decompensate in the past 1 decade of life. So there comes the common causes are autoimmune hepatitis, Wilson, and then you see if it is the infant biliary atresia, we get a lot of patients of progressive familial intrahepatic cholestasis, etc. So what I will try to give you some case-based presentation highlighting the difficulties we face in diagnosing autoimmune hepatitis and Wilson disease. Probably that will help you in your day-to-day practice. I don't think that talking about biliary atresia and PFIC is going to make any sense in this forum. Now, starting with autoimmune hepatitis, this is the latest publication of hepatology for both adult and children, ASLD practice guideline. What they say is that autoimmune hepatitis has a varied manifestation. It can have a symptomatic, asymptomatic, and there is a new entity called acute severe hepatitis. But 1/3 of patients of autoimmune hepatitis, they can come with a acute hepatic illness. They can have acute hepatitis, acute liver failure, or ACLF. So let's start with a case. This was a 3.5 years old girl who presented last year with a 25 days history of jaundice, preceded by prodrome, and she developed ascites in the form of abdominal distension within a month. The past 4 weeks of illness, she was treated outside, and then distension subsided with diuretics. No past history of jaundice. So what possibility will you think at this stage? This child has jaundice preceded by prodrome of shorter duration, but this child developed distension suggestive of ascites within 4 weeks. So this is qualified to be considered as acute and chronic liver failure, or then it may be everything is acute liver failure, where you can get the ascites as a presentation. Now, all of us are using this ACLF definition of Asia Pacific Liver Disease Society, and within 4 weeks decompensation you consider ACLF. When you think about ACLF, you consider acute, means acute viral hepatitis like A, B, E or drug-induced hepatitis, and at this age of 4 years, 3.5 years, underlying chronic liver disease, you think it could be autoimmune, Wilson, or some metabolic liver diseases like tyrosinemia or type 4 GSD. So let's have the investigation examination parameter. This child anthropometry showed that she was stunted. She has a significant reduction in the height. That means the disease is not altogether 4 weeks. Probably something going on, though it was not symptomatic. She was having icterus, but no stigmata of chronic liver disease. On para-abdominal examination, she didn't have any hepatosplenomegaly either. And at the point when we examined, there's no ascites, child was on diuretics and neurologically normal. So where we are, short duration of jaundice of just 25 days, which was preceded by prodrome, but decompensated within 4 weeks. Examination, there is stunting, but no stigmata of chronic liver disease, no hepatosplenomegaly. So is it an acute manifestation of chronic liver disease? Like we discussed, that 1/3 of autoimmune hepatitis can present as a acute hepatitis, or it was a ACLF, something causing decompensation underlying chronic liver disease. So let's have the investigation parameter. Hemogram was essentially normal. There is a hyperbilirubinemia conjugated type. She had low albumin. There is a prolonged INR, and SGPT was almost 10 times upper limit of normal. We got the ultrasound, there's some post echo texture, otherwise there's no other features to suggest cirrhosis. Acute markers, including extended viral markers like CMV, EBV, PARVO, all are negative. Wilson disease marker like K prime, ceruloplasmin normal, 24 hours urine copper was less than 40. So let's have the autoimmune parameters. She had ANA more than 1:100, ASMA more than 1:40. LKM negative, but IgG was more than 1.1 times upper limit of normal. So, do we have enough evidence to say this child was having autoimmune hepatitis, or do we need to do something else? So, we apply this simplified diagnostic criteria. It is very simple. You need just 4 parameters. Elevated autoimmune markers more than 1:80, you give 2 marks. Elevated IgG more than 1.1, give 2 marks. You get the absence of viral marker, another 2, and liver histopathology, if it is suggestive, give 2. So already this child without biopsy scores 6. You need to have a 6 to say probable, 7 or more is definite autoimmune hepatitis. So, but you did the liver biopsy to make it the definite. This is the liver biopsy showing classical picture, interface hepatitis. Then you have this empheropolysis on the left side and the right side, so acinar formation. So, and this is the reticulin stain showing there is a reticulin collapse around the porta, and mesom trichon show extensive fibrosis around the portal tract. So this child had a transjugular liver biopsy suggestive classical of autoimmune hepatitis, and we started this child on prednisolone induction followed by azathioprine, and she is the liver function test. She had dramatic response to our steroid therapy. The left hand side before steroid and after steroid, INR improved to 1.6, albumin normalized, and OTPT has decreased. So this is important. This is that Stravis criteria of diagnosing autoimmune hepatitis when patient presenting with acute liver failure. You need to have a biopsy, and remember this multi-acinar necrosis is not going to give you any diagnosis. To make a diagnosis of autoimmune hepatitis, you need to have at least this type 4 or type 5, where you need to have lymphoid aggregate, there is a perivenulitis and plasma cell infiltrate to say that this patient had autoimmune hepatitis. But autoantibodies, how significant are they in making a diagnosis of autoimmune hepatitis? So this is a study done in SGPGA. This is an adult study. They have done the autoimmune markers in both known and unknown cases of chronic liver disease. Known cases of chronic liver disease including alcohol, HCV, hepatitis B, and what they have shown that irrespective of the etiology, almost 40% patient had autoantibody positivity. That includes the ANA, ASMA, NANA, LKM. So, and IgG elevation is not related to the underlying disease, and almost similar picture was seen when it is a cryptogenic cirrhosis. So, any form of chronic liver disease, whether it is a known like alcohol, hepatitis B, C, or cryptogenic, almost a third of them have autoantibody positivity. So, detection of autoantibody in a setting of chronic liver disease is not necessarily indicate the diagnosis of autoimmune hepatitis. We have to be careful about. Then I fish out some studies. What about the acute hepatitis? These are all adult studies. The first study is from Korea. Has shown the autoantibody positive in acute hepatitis A is almost 35% of the cases, and the second study showed in hepatitis E, this figure is almost 37%. So what does it mean? It is common to see autoantibodies in acute viral hepatitis, and their presence does not necessarily indicate underlying autoimmune hepatitis. So let's see another patient. This is 5-year-old girl, almost similar presentation, jaundice with prodrome for 4 weeks. She developed ascites within 4 weeks, no past history of jaundice. Again, same analysis, ACLF versus ALF. And here anthropometry normal, there is no stunting. The previous girl had stunting, this child didn't have. There is edema, there is icterus, however no stigmata of chronic liver disease. Abdominal examination showed a small liver and ascites. So the same problem, short duration with early decompensation, and we thought it is the acute manifestation of chronic liver disease or ACLF, and investigated, and investigation showed very high bilirubin 24, low albumin, prolonged INR, OTPT elevation, ultrasound, there is some post-ecotexture, nothing else, and ascites, acute markers negative, Wilson disease workup negative, normal ceruloplasmin, no capring, 24 hours urine copper was normal, and we got the autoimmune hepatitis workup, is a positive, autoimmune markers positive, ANA is more than 1:100 and IgG more than 1.1. So the same, you apply the simplified diagnostic criteria. This patient is also having the 6 criteria, 6 short of biopsy means probable. So we did liver biopsy to make it definite, but this liver biopsy, previous child, I showed the liver biopsy was classical of autoimmune. But here there is only multi-acinar necrosis, no features to suggest autoimmune hepatitis. However, this child was not improving. She was deteriorating. So with the diagnosis of probable autoimmune, we started this child on steroid. Now see what happened. After starting steroid, all hell broke for this girl. She developed all known complications for autoimmune hepatitis, of steroid therapy. Her liver function test was worsening. She developed toxicity of steroid in the form of high blood pressure. She was on antihypertensive. She developed raised intraocular pressure on therapy. She developed blood sugar, very high blood sugar requiring insulin. She developed sepsis. So we need to stop the steroid, and after stopping steroid, this child gradually improved over the next 2 months. And this is the liver function test before starting steroid, after starting steroid, after stopping steroid. She is progressively improved. We don't know the diagnosis, but definitely this was not autoimmune hepatitis. So what we have learned from this patient, the steroids are not panacea. Don't use steroid right and left with a presumptive diagnosis of autoimmune hepatitis. False positive autoantibodies are quite common. It is not uncommon. It is very common. Irrespective of the etiology of the liver disease, irrespective of the age of the patient, both in adult and in children. So liver biopsy is essential to make a definitive diagnosis of autoimmune hepatitis. Even if in a patient of acute liver failure, you need to do a transjugular liver biopsy to make it sure this is autoimmune, and simplified autoimmune diagnostic criteria may not be useful in a setting of acute liver failure, because I showed that without biopsy also you get sick and you are tempted to start steroid, and the things may not go in the right direction. Now this is another aspect of ACLF. When a patient comes within 4 weeks of jaundice developing ascites and encephalopathy, we put a level of ACLF and we try to find out the underlying chronic liver disease patient. But in Indian setting, we do see a significant proportion of simple acute viral hepatitis can have features of ascites, can have splenomegaly. So these are the two studies we have done. One is from PGI Chandigarh when I was there, and then our recent study from SGPGI. We have shown ascites can be a presentation of acute viral hepatitis without having underlying chronic liver disease in 8 to 30% of the cases. This ascites is much more common in acute liver failure. Half of them will have ascites. And acute liver failure, it is easy to understand why do they develop ascites, because there is a sinusoidal portal hypertension because of the reticulum collapse. The portal hypertension will give rise to ascites, but without acute liver failure, what we have seen, this patient who are having ascites and acute viral hepatitis, they have a low total protein and albumin. Maybe there is a nutritional factor. Already they are hypoalbuminic, over and above acute hepatitis is giving rise to ascites. A proportion of acute viral hepatitis can have splenomegaly also. So it is very important to differentiate a patient who is coming with a short duration with decompensation. Is it really ACLF or atypical acute viral hepatitis? We need a proper follow-up. So this is a child who came with a 2 months history of jaundice, but this child developed decompensation early. Almost similar thing, ascites within 4 weeks, ACLF versus acute viral hepatitis. Atypical examination didn't help, except that liver was palpable 3 centimeters and 2 centimeters spleen. So we thought of the same line, underlying chronic liver disease, or it is a acute. You see the liver function tells the difference. In acute viral hepatitis, you get sky-high enzymes. The SGOT-PT were in thousands in this patient, though albumin was low 3.2 and INR was deranged, and ultrasound didn't show much except that altered ecotexture. This child has a viral marker positive, IgM anti-hepatitis A positive, Wilson marker negative. However, this is the spoiler. You do autoimmune hepatitis marker, you will get positive. This child also had low titer of anti-smooth muscle antibody and IgG was elevated. This patient we didn't do liver biopsy because our suspicion was strong about atypical presentation of acute viral hepatitis. This child improved with conservative management, and this is the serial liver function test. This is very important. Before telling that everything was acute, no chronic liver disease, you need to show the normalization on follow-up, and we did have a very good follow-up with a absolutely bang normal liver function test. What about the Wilson disease? Wilson disease also can have varied manifestation, but clinically symptomatic hepatic manifestation is very rare before 5 years. So that's why I said that less than 4 years, we think about other causes of metabolic liver disease more than 4 years. It's a common garden variety, autoimmune Wilson. And Wilson can present with acute hepatitis, fatty liver, acute liver failure, and usual chronic liver disease. This is a 6-year-old boy who presented with, again, the short history of jaundice, and developed decompensation, almost similar analysis, ACLF, ALF, but on examination, this child did have hepatosplenomegaly. Besides having jaundice and pedal edema, this palm liver, big spleen, obviously this was underlying chronic liver disease, this child has decompensated. So, investigation showed low albumin, prolonged INR, SGOT-PT OT is more than the PT. Endoscopy showed varices, so no doubt this child had chronic liver disease, viral markers negative. Again, spoiler. You do autoimmune, it's positive, IgG elevated, but this child had bilateral KF, this is no problem. Cellular plasmin was normal, however. You are expecting low cellular plasmin, it was 36, but urine copper is very high. So we thought of Wilson disease, it was not autoimmune, and we have the liver biopsy, which is showing that extensive fibrosis, nodule formation, and there is a balloon degeneration, Mallory's hyalin, and we have this copper staining rhodomine stain positive, liver copper we did, and it was elevated. So it was a Wilson disease, put on deep penicillamine, but this child deteriorated, developed hemophagocytic lymphohistiocytosis, passed away. Another patient, this is a classical presentation of acute Wilson. This girl, 9 years old, presented with short duration of jaundice. However, this child was having cola color urine with altered sensorium for 1 day, suggestive of IB hemolysis. So when there is a acute presentation with IB hemolysis, so what are the possibilities? It can be acute viral hepatitis with underlying G6PD, giving rise to IB hemolysis, or Wilson with IB hemolysis and autoimmune hepatitis with autoimmune hemolytic anemia. So on examination, this child had deep icterus, anasarcas, he had big liver, no splenomegaly. So investigation very high jaundice. And half of it is unconjugated, suggestive of underlying hemolysis, low albumin, prolonged INR, acute viral marker negative, some of the autoimmune markers positive, and Wilson marker. Serum cellular plasmin was normal, again 55. But urine copper is very high, 3000 microgram per day, more than 100 is always abnormal. And fulminant Wilson, you take this ratio in fulminant Wilson, AST to ALT ratio more than 2.2, because they have hemolysis, SGOT is released from there. This patient has. Alkaline phosphatase bilirubin is more than 4, both of them are there. In addition, this child had Coombs negative autoimmune hemolytic anemia. So all this thing is suggesting this is a fulminant Wilson, put on depend. We have done plasmapheresis because there is ongoing hemolysis, but we couldn't say the liver transplant could not be organized. Lesson learned, acute liver failure-like presentation with IV hemolysis, think about fulminant Wilson disease. AST to ALT more than 2:2 and alkaline phosphatase to bilirubin more less than 4. It is applicable to diagnose only fulminant Wilson. Don't apply it to common garden variety of Wilson disease. Remember, the serum cellular plasmin is the inflammatory marker. If there is acute inflammation, it will be elevated even in Wilson disease. I showed you 2 cases, both the cases cellular plasmin was normal, it was not low. And cellular plasmin is synthesized in the liver. When there is a very poor liver function, low albumin, so all the synthetic function is gone, cellular plasmin may be low in that state also. So survival of acute Wilson without liver transplant is very rare. Now this is the ASLD criteria to diagnose Wilson disease. You need to have 3 cellular plasmin low, KF ring positive, urine copper high to make a diagnosis. But any other combination, it suggests you need to have liver copper. It's very difficult to get a liver copper test to make a diagnosis. Even the liver copper is not diagnostic, you need to have a mutation analysis to make a diagnosis. Now what we propose in our day-to-day setup in a country like us, when you're suspecting Wilson, if you have all 3 positive, is definite. If there is any other combination, don't hesitate to start therapy. As I said, that cellular plasmin cellular plasmin level can be high, can be low, whether with a Wilson disease or not. So if there is a high cellular plasmin because of inflammation, you treat the inflammation, on liver function test is stabilized. If it is a Wilson, cellular plasmin definitely will go down. You don't have any situation where normal cellular plasmin Wilson disease. So then Wilson disease diagnosis is confirmed. But if the cellular plasmin, despite improvement of liver function, remains normal, that is no Wilson, you can discontinue therapy. So to conclude, approach to a child of chronic liver disease depends on the age of presentation and type of presentation. In different age group of different kind of liver disease, and acute presentation with ascites. Beside thinking of ACLA, we have to keep the atypical presentation of acute viral hepatitis also. When this child coming with the hemolysis, think about the Wilson disease and acute hepatitis, maybe a presentation of autoimmune hepatitis, but remember the pitfalls in interpreting autoimmune markers in other conditions, other form of liver disease also. Thanks for your patience.
Regarding Wilson's, when the test can be fallaciously positive. Sir, I'd like to ask just one question. As you said that acute viral hepatitis with ascites is there, do these patients have more complications in the form of encephalopathy?
Very nice question. What we have seen that ascitic form of acute viral hepatitis, they can have complications like SBP also. And ascites is much more common in a patient with acute liver failure. When there is acute liver failure, half of them have ascites versus when there is a common garden variety of acute viral hepatitis around 10 or 20%. So encephalopathy, yes, in a acute liver failure, encephalopathy, ascites, SBP, all these things can happen.
Hi Ujjal, nice talk. 2 things I wanted to discuss. One is in Wilson disease, acute fulminant, as you said, cerebral plasmin may be faulty. And urinary copper, usually we have to take a 24-hour sample, and with us it takes 2-3 days, at least 3 days for reports to come. So if we are strongly suspecting, what do you suggest? Shall we start them on D-penicillamine or something else?
I always say, whenever you are suspecting, D-pen is not going to change any other form of liver disease. You start, but remember when to stop. What we do in any setting, with any reason, we start therapy, but subsequently we forget to confirm the diagnosis. But last slide I wanted to stress that ceruloplasmin can vary. It may be low, it may be high, it may be low without Wilson also, it may be high in Wilson also. So you start, don't delay. Because by delaying the therapy, you are not going to doing any good to the patient at all.
So any role of zinc or trantine?
See, the comparison between the D-penicillamine and trantine, as far as efficacy is concerned, D-penicillamine is more effective, more efficacious as a chelating agent than trantine. Side effect profile is better with trantine, so there is no point in starting trantine as a first line of therapy in Wilson disease. It is a very expensive drug. When there is you are pushed to the corner, child develop complication or adverse event related to the D-penicillamine, you start. Zinc is a highly controversial topic. See, when you are treating a disease, what is your target? Target is to remove copper. What is the mechanism of action of zinc? Zinc, it prevents the absorption of the copper. It does not chelate the copper. When the patient comes with a disease, Wilson disease, full of copper in the liver, brain, you need to remove. Zinc is not going to help. Problem with the zinc. Zinc interferes the absorption of D-penicillamine. Now if you both the drug taken together, then the D-pen efficacy will go down. So you have to be very careful before starting zinc. There should be a gap between these two therapies, and remember, combination zinc and D-pen there is no study to say that there is additive effect.
Thanks. Secondly, in AIH, in adults also we face a lot of problem because again the markers can be falsely positive in majority of diseases. So, and biopsy is often inconclusive. How to, you said that don't use steroids empirically, but when all causes have been ruled out, we are compelled to use sometimes.
Yeah, this is the reality of life, but I guess your other half helps you a lot. We heavily rely on histopathology, and our pathologists most of the time they bails are out whether it is autoimmune or not by giving the proper histopathology report.
Excellent talk, Professor Ujjal. My question is about fulminant Wilsonian. You said once you have suspected a diagnosis, but if it's a fulminant Wilsonian, you still would like to start with D-pen, or you will straight away go for
transplant? Yes, I can guess what do you want me to say. D-penicillamine in a fulminant Wilson probably is not going to change the picture. It is just gambling. You are taking a chance. If you have a facility available, send them. All acute liver failure in that sense. You don't owe it. Even the acute liver failure due to autoimmune, your chances of survival with steroid is also less than 50%. So that all acute liver failure patient on the day one should be assessed for liver transplant. Especially if it is a Wilson, chances absolutely big. Whether you give the plasma therapy or you do the exchange.
You said, but of late people have started claiming some good results with plasma exchange. What is your experience?
We tried around 4 patients, only 1 patient survived, but you cannot say that 25% survival is a good and number is less. But we don't have clear-cut evidence this single volume or double volume plasma exchange changes the outcome of fulminant Wilson. So this is just a few case series, but liver transplant is the answer for fulminant Wilson.
Thank you.
Thank you, sir, for nice presentation. Sir, my question is about chronic hepatitis C in children. At what age you want to start treatment? Above the 12-year or 14-year? Or up to what age you wait for hepatitis C treatment?
Hepatitis C? Oh no, now not 12 years. We have the recommendation from 6 years onwards. You can start treatment with a directly acting antiviral therapy.
Very short questions.
Hello, sir.
Dr. Tahan Shah, transplant surgeon, sir. Just one small question, sir. Do you need to stop depenicillamine before if you're planning a patient for transplant surgery?
I don't think we stop, but anyway, if the patient is going for transplant, there is no point
So
of
the point is,
valid point. You have a wound healing problem with penicillamine and this thing. So once patient is going for transplant, you stop penicillamine.
Sir, stopping it for a longer period, are there chances that the patient
Yes.
may suddenly go have a fulminant course? Because one patient we lost due to COVID. The patient contracted COVID, she was planned for the transplant, and we stopped penicillamine, and she went into fulminant
Yes,
failure.
this is a problem. This is one of the problem of sudden stoppage of depenicillamine is they can come back with a fulminant presentation. I don't think you should take a chance of stopping and waiting for transplant for a couple of months.
She contracted COVID actually. Thank you so much.